Hello, Holistic. Our topic today will be about breaking bad news in palliative care. Before we start, I'm just kind of sharing with you a kind of a poll here. Uh, and this was asked to regular layman people about palliative care, whether they had an understanding of palliative care before it was explained to them or not. So in this poll, basically only 12% mentioned that they knew about palliative care. So this kind of let us know that we need to educate about palliative care before you ask the patients to make decisions. Objectives of this presentation uh, is basically reviewing the fundamental components of effective communication, explore boundary issues, discuss potential barriers to effective communication, and consider approaches and framework to challenging communication, what we call the spikes protocol. Palliative care is about basically symptom management, advanced directives, decision making, hospice care, communication, and goals of care. As you see, communication plays a pivotal role in palliative setting. First, we'll start with prognostication. So, what is prognostication? It's a prediction of possible future outcomes of a treatment or a disease course based on medical knowledge and experience. Prognostication is foreseeing, estimating prognosis, and foretelling, discussing prognosis. Foretelling is delivery of prognostic information and longitudinal process of communication. So, what is communication then? It is the act by which information is shared between humans. Such encounters may cover desires, needs, perceptions, knowledge, and affective states. Start with understanding the person that you are talking to. This is what we call patient centered care. The attitude, beliefs, context, decision making, and environment. Also, try to understand the spiritual, uh, you know, anatomy of this patient. We have a nice protocol called the FICA. All right, ask four questions: faith, belief and meaning, importance and influence, community, A for action in care. FICA for spiritual assessment. Will giving a terminal ill patient an accurate prognosis result in loss of hope? Studies have shown that giving prognostic information to patients does not cause hopelessness. Patients want honesty from their physicians. False optimism can lead to patients choosing interventions that would have not otherwise chosen if they have a realistic prognosis. Patients do not want over optimistic or pessimistic presentations of prognosis. Do patients want to know? Well, um, you know, perceptions of older patients, caregivers, and clinicians. Those who did not have a prognosis conversation were asked, do you want one? Patients, 50% said yes, 40% said no, 5% said, I don't know. Caregivers, 75% said yes, 23% said no, and 2% said, I don't know. Barriers of communication. The barriers could be physical, could be gender, could be emotional, could be time barriers, and could be cultural barriers. Communication paradox. When you start the communication process with your patients, okay, you have to keep things balanced. So, number one, the content. Uh, Make sure it's optimal, not too little, not too much. Timing, not too early, not too late. The nature of the conversation should not be over pessimistic nor over optimistic. Science, we need to be accurate. Art, we need to be general. Um, and when I say general, means that do not get very sophisticated about detail when you talk to your patients. Try to give them the big picture. And lastly, early palliative care referral. Medical physicians versus palliative physicians. As far as prognostication, medical physicians 63% are optimistic, 20 accurate, and 17% pessimistic. Palliative care physicians 26.8 optimistic, 57.6 accurate, 15.6 pessimistic. And this basically shows us that palliative care physicians are more trained with these conversations and dialogues than regular medical doctors. Okay, we jump into how you deal with difficult questions. Okay, most of us answer honestly, or decline to answer, or telling a white lie or half a truth. This can compromise our position, rapport, trustworthiness, and likability. So, how you answer a difficult question? First, acknowledge and validate and normalize. For example, that's a very good question and one that we should talk about. I'm wondering if something has come up that prompted you to ask this. Gently explore the thoughts and understanding. It would help me to have a feel for what your understanding is of your condition and what you might expect. Respond, if possible and appropriate. If you feel unable to provide a satisfactory reply, then be honest about that and indicate how you will help them explore that issue. Silence is sometimes the most appropriate response to difficult questions, followed by tell me more. Silence, tell me more. Conveying prognosis, giving a prognosis frankly and clearly, but with empathy. Most important when giving prognosis is what most important to them. For example, what concerns you the most about your diagnosis? What would you like to know about your illness? Is there someone else that should be here? When giving prognosis, it's important to give ranges rather than specific time and date. So, in other words, you say hours to days, days to weeks, weeks to months. The elephant in the room. What is the elephant in the room here? Is talking about death itself or saying the D word. Many people think about they might experience as things change and they become closer to dying. Have you thought about this regarding yourself? You want me to talk to you about changes? Or first, let's talk about what you should not expect. So when you start the talking about the death or the D word, okay, first start what with the patients should not expect. Like for example, pain should cannot be controlled, all right, or breathing issues, or losing your mind. These things should not be uh, happening because you should be taking care of these. If any of these problems come up, I will make sure that you are comfortable and calm. even if it means that with medication we use, you'll be sleeping most of the time, or possibly all of the time. Gradually, your body systems will shut down, and at the end, your heart will stop while you are sleeping. So, this is the way you talk about death to these patients. It should be very smooth and nice, okay? You should not frighten your patients about that. Um, we're going to talk about some of the communication skills, and I put the link up there from MD Anderson. They have a nice PDF that you can look up. I think it's one of the most, comprehensive and, uh, you know, uh, thorough at the same time. Uh, First, class protocol. Class protocol is about, clinical interviews, just regular clinical interviews. Context, L for listening, A for acknowledge, S for strategy, and S for summary. Okay? Spikes protocol. And we're going to spend some time on the Spikes protocol because it's the most important one as far as we're concerned. Spikes protocol is setting up the conversation. P for perception, I for invitation, K for knowledge, E for emotions, and S for strategy and summary. The Sparks protocol was put forward by Dr. Robert Buckman. He used to be a University of Toronto professor, and he has a lot of you know uh, things to offer here in the palliative care. Uh, he published around 14 books. One of them, I don't know what to say, how to help and support someone who's dying, and how to break bad news. And he's the founder of the Spikes Protocol for breaking bad news. He had also Magic or Medicine, a very famous television series about complementary medicine that won the Gemini Award. Spikes protocol, setting, perception, invitation, knowledge, emotion, and summarize. We'll start with the setting. The setting is about setting the stage, physical state setting, and who should be present. So first, create an appropriate physical setting, like a quiet, comfortable room. Turn off the beeper. Check personal appearance. Have participants, including yourself, sitting down. Determine who should be present as the patient who need to be in the meeting. Make sure you know your basic information about the patient disease, prognosis, treatment options. Make sure the legal decision maker is available during the meeting. Also, if there's a kind of a problem with the language, you need to obtain a skilled medical interpreter. Even you can use a phone translation services if necessary. Perception, determining what the patient and family knows. Determine what patient and family knows. Make no assumptions. Example, what is your understanding of your patient's present condition? What have the doctors told you? What did you think about what's going on? What have you been told about all of this so far? Are you worried that this might be something serious? Invitation. Ask permission to share the information. Are you a kind of person who prefers to know all the details about what's going on? How much information would you like me to give you about the diagnosis and treatment? Ask the patient if he or she would prefer to have a family member told first. Factors that would affect the information sharing, including culture, health, literacy, developmental level, and aging. Knowledge. Share the information with the patient, proxy, and family. Speak slowly, deliberately, and clearly. Give a fair warning. For example, I'm afraid I have some bad news. Present bad news in a succinct and direct manner. Sit quietly. Give an early opportunity for questions and comments. Present information at the patient's or family pace. And I want to just stress on the last point here because we all do the same mistake. We're always overwhelmed with the amount of work inside our, hospital or clinic, and usually you didn't give the patient enough time to talk to you. Okay, the you're trying to push the conversation so you see your next patient, and this is really very uncomfortable for the patient and the family. Empathy. Recognize and acknowledge patients' and families' emotions. Listen carefully and acknowledge patients' and family emotions, for example, by reflecting both the meaning and emotion uh, of their response. How does that make you feel? What do you make uh, of what I've just told you? Identify the source or cause of the emotion. Show the patient or surrogate that you identify the emotion and its origin. For example, hearing the test results is clearly a major shock for you. Obviously, this is a piece of news. It's very upsetting. Empathetic silence. Wait for them to take a deep breath and process the bad news. Answer questions patiently. Be sensitive and compassionate. Respond to the patient or surrogate thoughts and feelings. Meaning of empathy. Understand another state of mind or empathy is the capacity to recognize emotion. It is often characterized as the ability to put oneself into another's shoes or to, in some way, experience the outlook or emotions of another being within oneself. There is a difference. There is a difference between pity, sympathy, empathy, and compassion. So sympathy, I care about you. Empathy, I feel your pain. And compassion, I want to relieve your pain. And this shows you, the limb here, the x-axis, the effort that you need to put. Okay, so the higher you go up, the more effort you need to do, and on the y-axis, uh, basically the understanding and engagement. So as you get to the right side, you have more understanding and you are more engaged with the patient. Summary, finalizing the plan. Agree on a specific follow-up plan. For example, I will return later today. Write down any questions. Make sure this plan meets the patient's needs. Involve other team members in the follow-up. Clarifications. Further questions. Are other supports wanted or needed, such as social worker or pastoral care? Do they want to help in discussing with relatives, friends? What are the next steps? All right, we'll get into other protocols that are very useful as well. Cohen's protocol is used when disclosing a medical error, when there is a sudden deterioration in the patient condition, or when the patient passes away and death has to be announced. It stands for context, opening shot, narrative, emotions, strategy, and summary. It is important to be honest and to have a strategy in these situations. It is also important to reassure the family that the physician will do his best to rectify the mistake if there is one. Cohen's protocol. Eve protocol. The Eve protocol is used for anytime there are strong emotions during the conversation. E for exploring the emotion, V for validating the emotion, E for empathetic response. Buster protocol. You remember the name of the dog here from the cartoon? His name is Buster. Buster protocol is used for discussing challenging conversations with the patients and their caregivers. Be prepared, use non judgmental listening, 6-second rule, tell me more statements, empathize and validate, respond with the wish statement. Balance protocol. A balance is a communication protocol encompasses beliefs and values, ambience, the role of interpreters for language and health information, affiliations, uh, including religious, social, and cultural values, social support network challenges faced by patients, and economics or financial situation. Effective communication is based on this model increases the patient satisfaction and produces fruitful therapeutic relationships. So, in other words, this protocol is about, you know, language or cultural or religious or even social difference. B for beliefs, A for ambience, like living situation, L for language, A for affiliations, community ties, religious, spiritual beliefs, N for network, social support system, C for challenges, like cancer-related risk at home, E for economic, socioeconomic status, and community resources. Timer protocol. Timer protocol is one used for successful conversation. T for think through the encounter ahead of the time. Introduce issues. Manage the discussion. Establish a plan and expectations. Revisit and give feedback. We'll end with the key learning points of this presentation here. Prognosis, a prediction of possible future outcomes of a treatment or a disease course based on medical knowledge and experience. Communication is the act by which information is shared between humans, discuss potential barriers to effective communication in palliative care, consider and approaches framework to challenging communication, such as Spike's protocol. Thank you.